I'm going to be talking to you about what some people consider to be a delicate subject of cancer, and would remind you that what we're talking about today is science rather than policy. Policy waits to be thrashed out, in fact, by many of the people in this room. But we'll just talk about it in terms of the science, and I would like you to follow along and reach your own conclusions. We can start with the first slide, if you don't mind. Okay. Throughout the history of cancer, there have been a number of theories that have been proposed to account for cancer etiology. And these started out with a two-hit theory as early as 1902. And they all assumed that the primary lesion of cancer was damage to the DNA. And what I'll be talking to you today about is, after we discuss a few basic details, a mechanism by which vitamin D may play a role in carcinogenesis, because the existing models, including that model and the multi-hit model, could not account for the action of vitamin D against cancer. Yet we see it again and again in epidemiological studies. So what we'll do is we'll first start with some of the basics of the dose response, though, because it became apparent in the last few years that if we are to move from science into actual application of vitamin D in supervised settings or elsewhere, that we really do need to determine what the dose-response relationship is. We're beyond the point of determining whether vitamin D reduces the risk of cancer, I think. I think what we are into is an era of determining whether a small dose will do it, or an intermediate dose, or just what the dose that's needed is. So in a moment we'll be plunging into that, but while we're waiting for that, I'll tell you a little more about background on the theory. And that is that because vitamin D is not an antioxidant, it does not attack the DNA. And the actions that it takes suggest that we can think more about another part of the cell as the primary target, and that is the membrane. And in particular, the factors in the membrane that are related to intercellular adhesion. And George Palade, who received the Nobel Prize for this work and was a professor here, just died 3 weeks ago, but much credit should be given to his work. I think we could just proceed with the one that's on tap here, if that one isn't coming up. We have drawn from a number of disciplines in the development of the theory, and I'll be anxious to hear your reactions to it. However, what I'd like to do is present this over about a period of a half hour, and then we'll have an opportunity to talk about it and for you to ask questions after that. All right, well, here we go. Hold on to your bonnets. No relationships to disclose. And what we're going to do is, our objectives are these. And I'm going to show you typical dose-response relationships taken from the literature. I can't, not all papers unfortunately report the effect by dose. So I'll be showing you ones that report the effect by dose. Along the bottom is usually the mean level of serum 25-hydroxyvitamin D. Along the vertical axis is the odds ratios. And this one is rather like most of them. You see a p-value, you see a diagonal, points quite close to the line. Most of the variance actually is explained by the mean serum 25-OHD level. This has led epidemiology to begin to focus not so much on the oral intake of vitamin D, but on the serum level of vitamin D, its relationship to disease. These are observational studies, not experiments. Nonetheless, we felt that we should look at the implications of observational studies for what the dose would be that would eliminate 50% of the disease, assuming that the association is causal. And we talked about other percentages. It was Edward Giovannucci who said to me, why don't you just focus on 50%, and why don't we determine what the level is for each disease that can be prevented by a given level of 25-OHD if we are able to generalize from observational studies to causality. And we have a lot of reasons to be able to do that. And so this is what it was, 23 nanograms per ml. I'll generally be using nanograms per ml throughout the presentation. Those are still popular in epidemiology. This is the Feskinich et al. Study in the Harvard cohort, and this is the Nurses' Health Study. And you see a similar trend. Just, it's largely monotonic. You see a few flat spots here and there, but not greatly different from that of Tangria. And here it's 38 nanograms per ml. And this is what varies between studies. Not so much the overall existence of a diagonally downward curve, but rather the amount. So here it's 38 nanograms per ml. This is the Women's Health Initiative, which was designed 15 years ago in an era where we really didn't know anything about the right doses of vitamin D. But unfortunately, we collected blood at the beginning of the study. We see that there's a similar pattern with an intersection for 50% reduction of about 22 nanograms per ml. Quite hopeful. So these are the studies that are extant for colon cancer. Pooled odds ratio using the Oxford system, Roman system, and credit to Sharif Moore, who just joined us, is about 0.5, comparing the upper versus the lower quintile. And what we then did was to do a pooled dose response curve so that we had the benefit of the law of large numbers in estimating what the relationship was. And this shows you how it came out. And when the line was drawn, Sharif and I looked at it, Dr. Gorham, Dr. Garland, we said, well, that's a theoretical curve, isn't it? You don't get a straight line quite like that going through the points. But Sharif confirmed that that was the curve that the computer drew based on the Cochrane collaboration evidence-based medicine program. So it's very much like we saw some 28 years ago for calcium, surprisingly linear dose-response relationship. Of course, it's a logarithmic scale for the odds ratio as it's normally displayed, with a 50% reduction coming about where you would expect it, in about the middle of the studies that went into the meta-analysis. So here we have the fact that according to the epidemiological studies that exist, about 34 nanograms is associated with about a 50% reduction in incidence of colon cancer. Another way of looking at this is mortality, and Friedman and her colleagues at the National Cancer Institute looked at the NHANES cohort, which is a representative sample of the US population, or at least as close as they can get it, and they found that the higher the serum 25-hydroxyvitamin D, the lower the mortality, and by the time you got to greater than or equal to 80 nanomoles per liter, or 32 nanograms, this is that value that Dr. Haney talked about as a basic, you were down to 0.25, or about 75% of the death from colon cancer had been eliminated in this prospective study of pre-diagnostic D. And you can also look at this within the Women's Health Initiative against the placebos, which is a purer comparison than against all people not on vitamin D. And here you see there's also an effect, although not quite of statistical significance, but about a 30% reduction. So what about breast cancer? What we've been looking at so far is colon cancer. Is there a similar association? And Frank Garland and I, and later Ed Gorham, were led to this, pursue this epidemiologically because of the geographical gradient. There being much higher death rates from breast and colon cancer in the northern tier of the United States, particularly the Northeast, where a combination of latitude, weather, and pileup of the ozone layer accounts for only minimal ultraviolet B penetration of the atmosphere and only minimal vitamin D synthesis. Well, this is the study from Lowe et al. This happens to be in London, and this is what they found. Again, we're using this model of looking for what we would have to do to get rid of half the disease based on these studies. And this study, although a case control study, found that it would take about 48 nanograms per ml for lower risk. Unfortunately, took us up into the area of about 62 nanograms per ml, where the reduced risk was about 80%. So there's about 80% lower risk of breast cancer in people that were at 60 nanograms per ml. And here are the studies, well, these are studies combined. We're looking at the gradient overall, and it was 30% lower with 42 nanograms per ml. And finally, this is the pooled analysis. Pardon me, the previous was the Nurses' Health cohort. This one's a pooled analysis, and if you put all those studies together, you get a pattern that similar to that we saw for colon cancer, except that it takes more, 52 nanograms per ml, to achieve that 50% reduction point. So what about, often the question we get is, well, does it apply to premenopausal post-breast cancer, or just postmenopausal, or is it both? Fortunately, a study by Abbess et al. Recently published this year answers that question. These are the plasma 25-OHD quartiles along the bottom, And you see 1.0 is defined as the referent, and the odds ratio is showing how much less of it there is. If you get up to 12, even above 12 nanograms per ml, you've got 30% lower incidence of premenopausal breast cancer. And if you get up to just a little higher, 18 to 24, then it's 0.59, so it's about 40% lower. And then by the time you get up to even a rather low level of 24 nanograms per ml, considerably less than the 32 that we've talked about as a standard for sufficiency, it's down to about 55% reduction in premenopausal breast cancer. For postmenopausal breast cancer, the pattern is not terribly different in this large case control study. And you'll see that by the time we're at about 24 nanograms per ml, about 43% of this disease has been prevented. And one thing that people who are interested in dose response can't resist doing is to do extrapolations to the point, even though it's just an exercise, where the line would intersect 0 if it turned out that the association was real, and as we expect it is, and see the point at which there wouldn't be any more of the disease, taking previous deficiency diseases as a precedent. And that would hit somewhere around 48 nanograms per ml for postmenopausal women. That's a least squares line. The effect is the same for, approximately the same for mortality. This again is the NHANES cohort. It's the national cohort. And in that cohort, women who had greater than or equal to 25 nanograms per ml, even though that's way below the standard now, current standard, they had a reduction by 72% in death from breast cancer. And this was serum collected at the beginning of an approximately 8-year period in healthy women. So what about other cancers? One that's has not generated perhaps as much excitement as breast cancer, but is quite important as well, as ovarian cancer. And here you see the relationship from a study by Roger et al. Of the nurses cohort of median 25 OHD versus ovarian cancer. And R-squared is about 76, meaning about 75% of the variation in ovarian cancer in that cohort was could be accounted for by 25 OHD. It's in the 95% range for breast cancer, so it's a little less of strength of association for ovarian cancer, and we don't have nearly as many studies. And not extrapolating, but just with the data, we're at almost 50% with 30 nanograms per ml, which is comforting since we're regarding that as a key watershed point in vitamin D, serum 25-hydroxyvitamin D. Now, when we don't have studies of individuals, we plot these graphs based on data from the World Health Organization on the incidence, age-adjusted incidence of cancer in the world. And this gives you an idea of what's coming down the road. This paper by Moore et al. Was recently published. And what it shows is what we call smileys. Now, if there were no association between latitude and the cancer, these would be straight lines. But the more it smiles, the more it is an indication that it's an association. Fortunately, when we're working on these, we can read them across the room because it's not hard to detect whether it's smiling at you. And usually what we see is what you see on the right side, Iceland. Often it'll be once in a while typically Eastern European countries where there's a lot of air pollution and high latitude will mark the upper ends. You see Austria, Estonia. And then on the other side, in the southern hemisphere is shown as negative values. Very typically New Zealand and well, Chile, once in a while we'll have data from places like Tierra del Fuego, are typically on the horn on the left side. And it shows it's similar for men and women. And there are a number of cancers for which these smileys have been determined that are in various stages approaching publication for a variety of cancers. And I would like to comment at this point too that this builds on the work that William Grant did in identifying cancers beyond breast, ovarian, and colonic that were not known to be related to vitamin D deficiency until his work on an ecological basis clearly identified the relationship. So thank you. I see he's here in the audience. This graph was produced by Edward Giovannucci and his colleagues who modeled 25-hydroxyvitamin D and gave us an idea of the range of possible applicability of vitamin D, with the strongest effects he found in the upper aerodigestive tract, some effect for leukemia, significant effect, favorable effect for pancreatic cancer, colorectal cancer with the tightest confidence interval, which is rather what we expected that it would have. And as you can see, the other cancers listed. These are still under active investigation, of course. Dr. Haney, I don't think showed you this, but this is the randomized controlled clinical trial, and actually is it itself is a watershed point in the history of the vitamin D and cancer, where Haney and his colleagues, led by Joan Lappy, over a 4-year period enrolled about 1,000 healthy women, and these were postmenopausal women, with a baseline serum, a 25-OHD of about 29 nanograms. And they divided them into 3 groups, one of which received vitamin D3, one of which received calcium, and one of which received a placebo, and looked at all cancers as the outcome, although they were mainly breast, lung, and colorectal, as you would expect in a cohort of postmenopausal women. And this is what they found, with thanks to them for sharing the data. In the placebo group, about 8% of people developed cancer. In the calcium-only group, it was about 4%. And when calcium and vitamin D were given together, it was about 2.5% of the women. And this is highly statistically significant. And after having attended literally scores of presentations on chemotherapeutic agents, where it takes a magnifying glass, or if you're in the back, binoculars, to spot the difference between the curves, it was refreshing to see the Lappy et al. Publication where, again, the effect was detectable across the room. I suspect it was one of the reviewers that asked Lappy et al. To exclude deaths that occurred in the first year, thinking that maybe the effect would disappear, that it was had something to do with a phenomenon that was related to the first year. So when they did it, this is what they saw. It was about, well, as you can see, about a 6% recurrence of cancer in the placebo group. And that was about, well, maybe 2% or so, 2 or 3% in the calcium group. And then the calcium and vitamin D group, it was down to just about 1%. So there was an even more dramatic divergence of the curves. And we regard this study as the definitive study of the relationship, experiment of the relationship between vitamin D, calcium, and cancer. What about survival? Well, this is a new area, but differences are now being found in survival. This is reported at the ASCO meeting by Pamela Goodwin and her colleagues. And people who had lower than 20 nanograms per ml, here you can see the proportion without metastases over about an 8-year period. It was about maybe 7%, whereas this is actually the relative risk, whereas those who were sufficient had a much lower, 11.6-year period, had a much lower risk of metastatic breast cancer. And overall, this was about approximately reduction by half in the occurrence of metastatic breast cancer if you were in the top quintile of vitamin D at diagnosis. And then this is survival. This shows it in a different way. About a 40% reduction if you had greater than 30 nanograms per ml in your blood at the time of diagnosis. There's no chemotherapeutic agent that I've seen that produces quite this amount of reduction, although this is not administered as chemotherapy, but rather observed. And in colon cancer, fortunately, the group at Dana-Farber has recently published a study this year showing survival, and the vertical axis is the hazard ratio. And so 1.0 is the highest hazard that you might have. And then along the horizontal axis, we're showing the 25-OHD level. As you can see, there's a little bit of a flat in it, but as you step up to about, in this case, 40 nanograms per ml, you see about a reduction by about half, similar to that for breast cancer, in death among patients with colorectal cancer. Again, this is a difficult endpoint to achieve, and we salute the group at Dana-Farber for doing this study. First thing you need to do is to update your CV, and this is the introduction to a little bit of the MicroDarwinian theory. The theory, as I mentioned to you earlier, is that the first lesion is harm to the intercellular junction. This is all very speculative, but this is a theoretical framework that we're using. that this unleashes natural selection, and that natural selection, the most powerful force in nature, is the engine of growth of the cancer. It all starts out with tight junctions, and these junctions allow the cells to share resources and, more importantly, to inhibit each other's growth. In the absence of vitamin D or calcium, these tight junctions are endocytosed or otherwise become absent. And this is a picture of the junctions. They're structures that actually extend out from the cell membranes. There's a glue that sticks them together at the end, E-cadherin for the epithelial cell, which is downregulated in the absence of vitamin D, dramatically so. And these are different kinds of cadherins. My favorite is the flamingo cadherin, the third one shown here, that really binds the cells together quite tightly. The flamingo goosenecks extending into one cell, then the next, and back and forth and so on, producing contact inhibition. And this is a detail based on very complicated X-ray studies of what the junction looks like. It looks surprisingly like a Lionel train junction to me, but the 2 points go together quite closely, and interestingly enough, they depend on calcium. If the calcium is removed, these hinges fall apart. It's absolutely dependent on their presence, and it's dependent on the presence of cadherin, the glue that I talked about that's among the 2,000 proteins upregulated or downregulated in the cell by vitamin D and its metabolites by latest count. So this is a great moment in evolution, or in the evolution in this case of the tumor. The baseball is on the island and the ball players are wondering just what to do in order to get the game going again. An opportunity for a change. And here we have at the bottom things like Amphioxus, and at the top Charles Darwin, to whom we tip our hat with this moment. If there are no adherins present in a cell, and this accounts for 85% of the 3.25 billion years that life has been on Earth, then when cells divide, they go in opposite directions. But as soon as you have some form of adherin, and vitamin D is the outstanding upregulator of adherins, then you have multicellular growth. And it may be that vitamin D is either the witness or the agent of the conversion over the last 15% of life from not having solely unicellular organisms, but to having multicellular organisms. It may be that important, we don't know. In looking at cells, they're usually tightly stuck together and then pull apart. And to summarize this theory pretty quickly, in the vitamin D replete state, more or less the model, the brick and mortar model of tissue, epithelial tissue, can be said to exist. But when the vitamin D level is low, those intercellular junctions that look rather like candy canes in the top picture, they disappear, and the cells become less polarized, less cuboidal, tend to be rounded as in the photo or the diagram below, and no longer have much contact inhibition, because contact inhibition is mediated by the existence of intercellular junctions. And one thing that happens in these circumstances is that some of the cells revert to becoming stem cells, which has been proposed by Wicha and his colleagues this year. These stem cells then become rapidly dividing, as stem cells are. Their most aggressive progeny predominate, and we modeled this, and we found that even a 1% advantage will fill any tissue compartment in 9,000 generations, which is about 20 years in most epithelium. The most aggressive cells compete for the nutrients, and it's classic evolution. These cells don't know that this competition, natural selection, is leading to their ultimate destruction, because it's not a process that's driven by the end, what occurs at the end of the line. Then we think, and the reason I'm mentioning this is that vitamin D is involved at each of these phases, we believe. There's the invasion of the stroma, lymph vessel invasion, colonization of the lymph nodes, lymphatic transport to the brain, lung, liver, and bone. And while it seems maybe this is like a bit of an elementary exercise, the reason for showing it to you is to remind you that tight junctions are restorable as long as the vitamin D receptor system and its response elements are intact. It's quite a robust system. So the epidemiology suggests that at each of these stages, it may be possible to restore intercellular communication and contact inhibition, so that even once the basement membrane has been penetrated, it might still be quite possible, and it appears from the epidemiology that it is, to get these cells to once again stick together to inhibit each other's growth. And the big question is, what by the time the cells have reached the degree of de-differentiation seen in many metastases, whether there's any hope of action of vitamin D. But we don't know. but there's reasons to believe from the epidemiology that it works at all these stages. It says you raised it from a mutant seed, you whack it. Certainly they're products of mutation, but they need not depend on external carcinogens. They could represent infidelities of reproduction of the DNA. And if that's what it is, then we need to no longer devote almost all of our energy in science to the search for the carcinogen, but rather to a better understanding of the process and how we can abrogate it. These are just some gene fold changes for those of you that are interested in the specific genes that are influenced by vitamin D. And almost every group I have shown this, or a slide like it to, has a certain gene that's their favorite. My favorite happens to be E-cadherin because it's the glue that holds the cells together. But others are very interested in the keratin because it's important for the cytoskeleton and also for contact inhibition. And this list is actually 2,000 now. So that's just a flavor of it. I'll go through these very quickly. The primary lesion we propose is decoupling based on epidemiological grounds mainly, but the loss of intercellular communication, the rounding of the cells, loss of polarity, loss of contact inhibition, which leads to aberrant behaviors such as a cell converting from an ordinary epithelial cell to an epithelial stem cell, as which are proposed. And then actually a kind of devolution where there's penetration of the acellular basement membrane, our theory being that this can be stopped at any point. And this is simply a product of these very hungry cells, actively metabolic, needing amino acids that are present in the membrane that are essential, but they can't get otherwise. In the process of consuming it, they penetrate it, and when they penetrate it, then control is lost. And now we have it in the lymphatic system, and I'll just go quickly through it here. Getting stuck in the lymph node where it probably can also be arrested by restoring contact inhibition. Ultimately, metastasis, which vitamin D deficiency might create two problems with. One is the lack of tight junctions between these cells might allow the invaders to enter more readily, but also once inside, if they don't stick together well, then they'll spread more rapidly. The idea throughout the natural history of the cancer, based on this theory, would be to restore adhesion at every stage possible and harvest the benefit of contact inhibition, which is the oldest phenomenon known in cancer. Well, I'm almost at the wall. Let's see, should we take a couple more minutes here? The global impact, now something epidemiologists can't resist also, is to say, well, what if what we've just shown you is true? And for the moment, if you don't believe it, suspend your disbelief, then how many people would be saved by the findings that you've seen? And in North America, for colon cancer, and we calculate this based on where the people live by latitude and the data that you've shown, it would be 30-some% of the cancers of the colon. And that would be about 51,000 a year that would be prevented. And you can pick your country and see where the effect is likely to be greatest. It's greater at higher latitudes, but in Central and Eastern Europe, it could be 40,000 a year. And this is for breast cancer in the United States and Canada. It's about 50,000 deaths that would be prevented annually with a modest amount of vitamin D. Here we're talking about 2,000 units per day, and about 24,000 in Central and Eastern Europe. Even in Eastern Asia, 44,000 breast cancer deaths can be prevented. Much of Eastern Asia actually is quite northerly, and it was kind of surprising to us until we looked at the latitudes that were involved. Now, this was a graph, the design of which was suggested by Carol Baggerly, and we worked on it together. She said, well, how can we show how the doses needed to prevent rickets relate to the doses needed to prevent other diseases? So here's rickets. By the time we're up at 20 nanograms per ml, 99% of it is gone. And then we'll move on to type 1 diabetes. You'll hear more about that. But these are corresponding figures of amount that could be prevented with various doses. And this starts at 35 and ends about 55. And you'll hear more about that later. The references for each of these are shown below. Multiple sclerosis in the range of 50 to 60% with about 48 nanograms per ml on the average. All fractures, and this is still subject to debate, but we're talking about 50% at 40 nanograms. Again, still subject to very active debate. Falls, oddly enough, less subject to active debate, although many fewer studies. Incidentally, there are 750 studies, randomized controlled clinical trials of vitamin D and various outcomes in PubMed. Falls in women, maybe 3 studies. 55% of colon cancer with 35 nanograms. And here we are with breast cancer. It's harder, 52 nanograms for that 50% that we talked about, generalizing from the observational studies. Aggressive prostate cancer, and the effect is greatest for vitamin D early in life. Ovarian cancer at around 42 for about 20%. There are other factors being involved. Endometrial around 36. Hormonal factors are also involved. Renal cancer range from 50 to 67%, around 40 to 50. And non-Hodgkin's lymphoma, all cancers combined. This is based on the Lappy et al. Trial that Robert Haney was a co-investigator on. 75% preventable, around 52 nanograms per ml. Now, it gets to be so unbelievable that, you see things like this. Ask your doctor if taking a pill to solve all your problems is right for you. And we do have to bear in mind in the discovery of new pharmacological agents that typically they're regarded in a very happy way in the early phases, but not so much after a while, and then they come back and are better understood and find their place. There's a handout that we need to hand out that's in a black bag there just behind Dr. Garland. And what I want to mention to you briefly is what some people call the elephant in the room, or the gorilla in the room, and that's a study by Chablowski et al., recently published in the Journal of the National Cancer Institute. Yes, may as well hand it out. They're handing out the design of the study, and this is part of the Women's Health Initiative, a study conceived 15 years ago when it was a battle to even get a little bit of vitamin D added. And so vitamin D was put into one group and not the other, and this shows the study design. And it turned out that the amount of vitamin D that was given, 400 IU, produced at most a 4 nanogram, we'll pass them out later, but you'll get it before you go, a 4 nanogram difference in the amount of 25-OHD. And that didn't produce a difference, well, only a small one, a 5% lower mortality overall, and a 5% lower incidence of breast cancer. But more importantly, the study found a 20% lower incidence of breast cancer in women who were in the highest quintile of 25-hydroxyvitamin D. And it's easy to dismiss that until you stop to think that our whole rationale for early detection of breast cancer, which hinges on mammography, is expected to produce at most a 20% reduction in mortality, whereas even a modest amount of vitamin D in that study was associated with a 20% reduction in incidence, avoiding all the problems that occur between incidence and death. So just to keep in mind, though, that the randomized control part of the study did not find an effect, and that was also not present for colon cancer or precursors of colon cancer, which proved once and for all that 400 international units of vitamin D is too small an amount to do anything with respect to diseases other than rickets, as we expected. But nonetheless, you should be reminded of it. If you're to pick a place for what vitamin D status for your patients ought to be, we had to have a lot of discussion of this, whether it should be 32, 40, 50, or 60. And I must tell you that we vary from day to day. But over the last month or two, we thought that 60 is about right, but we would entertain arguments for about 50. But certainly not very much lower than that based on the data that you've seen. And as far as if you were to base the intake on the epidemiology policy issues that have not yet been worked out, but taking into account here the National Academy of Sciences, that adults would be getting about 2,000 international units. Children 1 to 12, about the same, infants 1,000, and you'll see the reasons for that. And the serum target would be from 40 to 60 nanograms per ml. That way we will not only avoid rickets, most certainly, but you will see a wide range of diseases that other investigators will talk to you about today that can similarly be at least put on hold maybe for a few centuries. Thank you.
Questions again?
Could you go back one slide?
We have a request to go back one slide.
A few slides back, you showed maybe 20 different enzymes that were using vitamin D. And I assume that with those proteins come some kind of trace mineral that, besides calcium, which isn't really a trace mineral, that the proteins use to become enzymes and drive their different reactions. Is there a list of things that people should take with vitamin D?
Oh, these are not that. This is just, again, we're talking here about science rather than application. These are compounds in the cell which are the products of the DNA which are upregulated in the presence of vitamin D. So someone who's had some vitamin D, either from the sun or from oral intake, this is what's happening in the cell. But there's nothing there that anyone would recommend taking in order to enhance the effects of vitamin D. It merely shows a step along the way from the vitamin D being absorbed by the cell until it produces its end organ effect.
Hi, my name is Rich Blumenthal, and you showed a chart that Bill Grant made where there's a bunch of horizontal lines, and it kind of looked to me like the early part of the top part of that chart made it look like increased vitamin D increases the risk of brain cancer or something. I was wondering if you could just elaborate on that and just clarify that.
Yes, you're referring to the graph. It was produced by Edward Giovannucci and his colleagues based on model levels of vitamin D. And it may be that vitamin D has a very beneficial effect on most cancers, but maybe not all. There are other factors involved in brain tumors that may overwhelm the effects of vitamin D. And we see this for some cancers. Very large intakes of cigarettes or alcohol completely overwhelm the beneficial effects of vitamin D. In that cohort, which includes veterinarians and others who work with a lot of sources of viral exposure, there may be factors that are beyond the capability of vitamin D to do anything. That would be my guess what it is.
Hey, David Sheridan from Houston. Progesterone deficiency is a huge factor in the incidence of breast cancer, and I was wondering, vitamin D is a hormone. Do you know of a relationship, vitamin D and progesterone metabolism?
Well, it's a good question, but they're not mutually exclusive. It turns out in the world of deficiency diseases, if a deficiency is present and a deficiency is addressed, other predisposing factors seem to become lost in the noise. And we think that's what's happening here, that all these tissues are hormone dependent. Many of them that are, where there's evidence of vitamin D preventive effect, the other factors are present, but they drop into the noise when the level of vitamin D is high enough to maintain the integrity of the tissue. And while there are growth factors that are important and are important in treatment, they become less relevant if the vitamin D is replete. Yes, sir.
Hi, yeah, Cedric. In the studies you showed correlating 25-hydroxy-D levels with risk of various types of cancers, how many of those accounted for PTH levels as a covariate?
Well, they don't typically. In an effort to achieve simplicity, the 25-hydroxy vitamin D is measured and the incidence of the disease is measured in such studies. There is a moderate correlation between 25-OHD and PTH. It's been seen in several studies, including a paper from our group in Rancho Bernardo. But it appears that in the limited amount of data that we have, that the 25-OHD is a better predictor of the cancer than the PTH. There are apparently other factors that are influencing the PTH, which introduce noise, make it a less efficient predictor of the cancer.